Assalamu alaikum. Good afternoon, everyone. I would like to thank the organizer for the invitation, and I'm delighted to introduce a dear friend, Dr. Mohamed Shelan. He is a senior consultant working at University of Bern. He is assistant professor. He has a lot of publication, and the stage is yours, Mohamed.
Thank you so much, Hissa. Thank you so much, the organizers, for the kind invitation. Today, I was asked to talk about the SBRT in prostate cancer. I have prepared a short overview about the landscape of SBRT in the current era. So those are my disclosures. And I divided the talk into three parts. The first part, I'll be talking about, giving a short overview about prostate cancer and treatment options that we have. And then the SBRT in the primary setting, and very short about the technology evolving. So the first part, we know that prostate cancer is a common disease in men, and we have in the last years a lot of awareness and screening that led that most of the cases being detected in the early stage. For this early stage, we have different treatment options. Just imagine a young patient got the diagnosis of prostate cancer, sitting with his urologist or family doctor, discussing different options. The patient can get watchful waiting or get a surgery. Radiation with or without ADT is an option. And then we have the newly evolved therapies like the cryotherapy, hypo, or nanoknife. But we still have two gold standards. The first is the surgery, and the second is the radiation. For many years, such a young, fit, sporty patient gets a prostatectomy, and radiotherapy was only an alternative for older patients with a lot of comorbidities and limited life expectancy. In the year 2016, there's the important publication from the PROTECT trial where radiation was compared to surgery and watchful waiting. And as you see, we don't have any differences in the prostate cancer-specific survival. Try that. Yes, we don't see any differences in the prostate cancer-specific survival between the three treatment options. However, the patient who got active surveillance had more evidence of metastasis in this case. The publication was updated in the year 2023, where the 15 years outcome was published. And as you see, the same results again. We don't have any changes or any significant changes in the prostate cancer-specific survival. However, still, the patient who underwent active surveillance had more evidence of metastasis. So it's mainly not about the mortality from prostate cancer, because it's really few. It's about the treatment toxicity and the quality of life. So this is the quality of life from the PROTECT trial. As you see, we compare the incontinence between the three arms. And as you see, radiation is always comparable to active surveillance. However, for the surgery, higher rates of incontinence after 6 months decreases to almost 20% after 6 years. The same for the intact sexual function. Radiation is almost comparable to the active surveillance. We know that we have some GI toxicities, about 6%, but this is due to the old radiation techniques. With this, I'd like to move to the second part, the stereotactic body radiation in the prostate cancer. We know we have 3 fractionation schedule, the standard fractionation over 8 weeks, and then we have the moderate hypofractionation over 4 weeks, and then the ultra hypofractionation in 5 sessions. As you see, the ultra hypofractionation delivers higher biological effective dose in this case, mostly given in 5 to 7 fractions. So if we check the NCCN guidelines, we have the moderate hypofractionation as the most preferred fractionation schedule for prostate cancer in all the setting mostly. And this is based on a lot of clinical trials, non-inferiority as well as superiority trials from UK and the US and Italy. So what about the evidence of stereotactic body radiation? This is the first trial from Denmark, where stereotactic body irradiation in 7 fractions was compared to standard fractionation. As you see, almost 1,200 patients received either 78 gray in 39 fractions or 7 fractions to a total dose of 42.7. And as you see, the GU toxicity and sexual function never show the difference. However, for the GI toxicity, we could see that in the ultra hypofractionated arm, there was somehow acute toxicity, little bit higher or significantly higher than the normal fractionation. However, this will resolve with time, and the patient up to 6 years, there is no differences in the GI toxicity. The second important trial I would like to show is the PACE-B trial from UK, led by Nicholas Fanas. And in this trial, patients were randomized either to 78 gray in 39 fraction or 62 gray in 20 fractions. And the experimental arm was the SBRT 36.25 to the PTV, and the CTV got an escalated dose to 40 gray in 5 fraction. And as you see, excellent biochemical outcome over 5 years. And this is the use of ADT. It's almost the same in both arms. And the GU toxicity +2 was somehow. So the conclusion of the trial included unfavorable intermediate risk. A lot of patients, mostly of the patients had unfavorable intermediate risk, and we reached excellent biochemical control up to 95%. This without ADT. That means that the trial met the expected or beyond the expectation in this case. So we compared the 5 fraction to the 7 fraction schedule, and we did not find any significant differences in terms of biochemical control. However, we could confirm that the GI toxicities in the 7 fraction schedule is a bit higher than the 5 fraction schedule. So the one another important trial is the PACE-A trial. In this case, we the same group from UK compared the ultra hypofractionation versus radical prostatectomy. In this case, very few numbers, but the primary endpoint was the urinary incontinence. And as you see, almost 50% from the patient who underwent surgery had incontinence, and only 6% in the radiation arm. This is how the incontinence happens over time. As you see, 4 weeks after the operation, almost 80% had incontinence. This will resolve with time. After 2 years, we'll have up to 50% having incontinence. With the SBRT, the numbers of the incontinence remains low. So what about the bowel habits? If you check that, we had only 6 patients, almost 12.5%, who had small problems with the bowel, and only 1 patient had moderate problems. So what about the sexual function? As you see, 20% only after surgery had intact sexual function. With radiation, the numbers were quite high, and this is how it's going to be over time. We had the SBRT arm. They had a little bit higher sexual intact function. In this case, this decreased after almost 6 months after radiation. After 24 months, there was some sort of resolve of the function. However, the patient who got surgery, they had a massive drop in the sexual domain in this case. So this is for the intermediate risk. What about the high-risk situation? We have the SHARP consortium, the data for almost 350 patients from 7 prospective trials with a median follow-up of 50 months almost, and most of the patients got ADT, and 19% got pelvic nodal irradiation. And as you see, the use of ADT in this case was very significant. The patient who did not get ADT had lower survival in this case. So another important data in my opinion is the data from the Hypoflame trial. In this trial, patient the prostate got 35 gray, and then there was a boost to the tumor to 50 gray, also 10 gray per fraction. And then, as you see, excellent 5 years biochemical relapse-free survival up to 93%. Also very low incidence of toxicities. Here you can see that very low incidence for the GI toxicity. As you see, grade 3 toxicities are really minimal. And this is how the sexual activity, of course, those patients get ADT in most of the cases. That's why you could see more grade 3 toxicity by the sexual domain. So what about the 5 fractions? We can consider the 5 fraction schedule as a standard of care. If there's any possibility to reduce the number of fractions, for that, the HERMS trial, it was a randomized trial. There was 46 patients with low to intermediate risk prostate cancer. A 5 fraction schedule was compared to 2 fraction schedule, 27 gray in 2 fractions. And this is the interim analysis for the first 20 patients. And as you see, no grade 3 toxicities in both arms. So one important publication is the TOFA meta-analysis combining the data from four prospective clinical trials in terms of biochemical control, no differences between the 2-fraction schedule or the 5-fraction schedule. And as you see, also for the toxicities, GU and GI, there is no differences. So furthermore, 1-fraction schedule, we have the Brosnet trial from Portugal, 5 fractions versus single fraction radiation. They called it virtual prostatectomy, but in this case, it was mentioned that the single fraction RT seems to be safe. However, the study was very small and had a short follow-up. Furthermore, we have the APROPT trial from Stefano Arcangeli from Italy, and as you see, it was 1 fraction 24 gray, and as you see, very low incidence of grade 2 and grade 3 toxicity, acute and late. So the one shot from Thomas Seeley recently published, and then they showed that the 2 years biochemical relapse-free survival is quite good. So what about the technology? For the technology, I mean here the addition of adaptation to the treatment. Usually we have 2 systems for adaptation, the MR-Linac and the ESO system. For the ESO system, it's too recent. There's no data about that so far. So I included only the trials using the MR-Linacs. We have the Mirage trial comparing the MR-guided radiation to the conventional Linac. It was 1-to-1 randomization. All the patient got 40 gray and 5 fraction, and nodal irradiation was allowed, 25 at 5 gray. And as you see, also very low incidence of grade 3 toxicity. And then as you see, the MR-Linac arm did not have any grade 3 toxicity. This is the toxicity in terms of genitourinary toxicity. There's no significant toxicities in the conventional arm and less toxicity in the MR-Linac arm. So one more important data from the momentum, it's a registry who are including prospective trials for patients who were treated by 1.5 Tesla MR-Linac. And this is also showing that the GI toxicities are very low. In this case, no grade 3 toxicities, and only up to 0.6% had acute genitourinary toxicity in this case. One more advantage that we can get using the MR-Linac is the nerve-sparing SBRT. As you see in this trial, the neurovascular bundle were able to be saved in almost 49% of the cases, and then 20% bilaterally and 68% unilaterally. So one important trial from Allison Tree is the Destination 1 trial. In this trial, they try to de-escalate the dose to the prostate and escalate the dose only to the dominant lesion. And as you see, and also the toxicities here were quite low. They had no grade 3 toxicity or higher adverse effects. With this, I would like to conclude 3 points. The first thing, we have level 1 evidence showing that radical prostatectomy is equivalent to radiation or vice versa. We know that SBRT to the prostate in 5 fraction is now a standard of care. 2 fraction is coming, 1 fraction might be possible. And we know that MR-guided radiation seems to be feasible and is associated with a very low toxicity profile. I would like to thank you and happy to take any questions.
Thank you, Dr. Mohamed, for the excellent presentation. Do you have any questions from the audience? Okay.
Andrew. It's actually an excellent question, I would say. It's mainly industry-based. I know the data from the trial led by Sonjonil, as far as I know from Ireland. Actually, there's no prospective data on that so far. They only finalized the accrual, and in my opinion, in Switzerland, it's not really cost-effective because we have very low grade 3 toxicities to the rectum. I have almost 1.8% based on the randomized clinical trials. So how far you could go with the spacer in this case, I'm not really quite sure. But it might be an issue in selected patients, but not for every patient, in my opinion. Please. Actually, in my practice, we use the compiums, but I know different centers using the fiducials. As far as I know, there's no specific improvement in the toxicity profile using the fiducials or the compium CTs. The data from the phase 3 trial showing that the CyberKnife-based SBRT might be favorable compared to the LINAC. However, we should interpret that with some sort of calmness, I would say. The study was Aquaray funded, so it's quite clear where it's going. Yes. We use the fiducial only if you were doing the robotic SBRT via CyberKnife, but for the adaptive, no. Actually, this was addressed by Andrew Loblau in a good publication. They showed no differences in that. But in my own practice, I feel that the patient who get radiation every second day, they get more, I would say, relaxed. They don't have this sort of stress with the treatment itself. So it's an objective improvement in this case might be taken in consideration. I know also data that Matthias Guckenberger is leading a trial on that for the patient, treating the patient once a week. And the data are not so far available, but what I heard from him yesterday that the patient relating that in a very good way, they could recover and no symptoms, even if they have large prostate or high IPSS score. Please. I myself not a brachytherapist, but I like brachytherapy. I would say it's a $1 million question. We don't have any prospective data, HDR versus brachy, but I know that one trial will be coming comparing brachy combined with external beam versus SBRT. In this case, the trial comes from Canada, from the Center of Andrew Loblau. But it's not in the early stage. It's mainly in the unfavorable intermediate risk as well as the high risk. I would say in my practice, we do not offer brachytherapy to intermediate risk patients. There's good reasons for that. First, the handling and also the anesthesia and the infection risk and all those stuff. And with the SBRT, you have a good alternative. The patient does not need to be admitted, and the toxicity profile is really good. You can even escalate the dose in the hypo flame trial. So I see brachytherapy as an option, but you will never get one-to-one comparison in this case.